I think of implants as basically paint for the artist. And the artist, where art comes from is the ability of the artist to use the tools at their discretion and to make something that's very artistic and very pleasing and hopefully has very good outcomes. So everything we're talking about here is simply adapting our tools that we have in place. One of those tools, if you will, are the surfaces. Now, there's a lot of discussion. As you mentioned earlier, when Brånemark was using the machined or turned implant surface of the 60s, it actually has, when it's handled right, by the right artist, it has good outcomes.
Right. Especially in denser bone. Sure.
In denser bone. We have gone through a series of different technologies. Now, currently we're in a moderately rough implant surface, usually created by some form of an acid exposure to an implant surface.
Or blasted.
Or blasted.
Or a combination, right.
Where do you see surfaces going? And frankly, do they need, have we reached the steady state for surfaces, and we should maybe redirect our attention to other issues?
I think it's a great question, and certainly I'm going to ask you the same question because I know you're so actively involved with manipulation of the bone reaction to surfaces. So we're going to reverse the discussion in a second. But I think it's important for the people out in the audience to recognize that the first thing is, what is osseointegration? Let's start with the pure basic example.
Okay.
When Brånemark first talked about direct contact of living bone to a load-carrying implant, he was talking on a light microscope level. At a light microscope level, we all have that famous 3-thread picture that he always describes in the bone right up against it. But we realize, of course, that the bone isn't directly touching it. You have the titanium now. On the electron microscope level, there is no direct contact. You have the titanium, as you know, the oxide forms on the titanium, and it's that oxide through a glycoprotein material like hyaluronic acid or chondroitin sulfate that interacts with the bone. So there's no space for, it's angstrom units, there's no space for fibrous tissue, but there is no real direct contact except on the light microscope level. It functions like an ankylosed tooth because there's no fibrous tissue, but in fact there is that slight space filled with probably glycoprotein material. You can address that better than I can. But here's the important thing. If you put a polished, people don't realize this, that if you put a polished titanium, and I know you do, but a lot of people don't realize that if I take a polished piece of pure titanium, same metal that we use for right now for any implant that integrates, and I polish it well, and I put it in, I make it look like a screw, but I polish it, I electro-polish it. I put the screw into the bone the same way we do with all our implants. Will it integrate? And the answer is no, even though it's commercially pure titanium. People think it's the titanium that's the key. That's not the key. The titanium it's nice because it has the oxide, which helps prevent leakage of titanium ions into the body. That's really what the oxide is doing more than anything, and therefore is biologically, it's not inert, but it's biologically acceptable to the body, and that's why orthopedics use it, so do we. But the polished part is interesting. So you asked about textures, let's start with that. You have to have some texture. Now, the machine texture that Brånemark gave us, left over after the threads were made from the rod of titanium, had striations in it. And that striations were not very rough, but rough enough for the bone to lock into mechanically. So that after a period of time, but it was slower to integrate because the bone couldn't lock into too much, other than a few little nooks and crannies. It didn't have the ability to lock in. So that's why in softer bone, that implant, one, it took longer to heal. We talked about 3 to 6 months in the original Brånemark implant because it was only machined. And in softer bone, and in grafted bone, we saw higher failure rates. In our own data, we saw that in sinus lifts, for example, we had only a success rate in the 70s with the machine. Where we knew any of the textured implants, we were at 95. Same grafting, same students, same faculty. With Dr. Fromm and myself and Dr. Wallace, we did the same work with the same students, and just changing the implant surface made a big difference. 70 plus percentile versus 95 percentile with all the other textured implants. That's what made the big leap away from the machined surface. But if we put the machined, but how rough is the other answer. TPS is rougher. Now, there's something called an RA or SA value, and I know you know that, but I'm mentioning it to our listeners. The RA or SA value, you'll see this in an article. And the RA, it's really the average height, it's really the depth of the valley. So if we're like two peaks, our two heads, you got the valley between us. Well, what's the average, and you got, how wide are my peaks and how deep are my valleys? So that's what roughness. Now the roughness that most people talk about is only this, the vertical part. And that's the RA, that's the main thing. Now Ann Winterberg and Albertson have certainly added other dimensions. You got the distance between the peaks, and also the valley going into the valley. So you got
the
a lot
waviness
of
going
the
down,
waviness going down,
up.
the bumps going on. You know, how bumpy is the road? So there's a lot of variables with roughness, and that's what's so crazy about it. So besides how wide are my peaks, how deep are my valleys, how fast do I go into the valley, and is it a bumpy road or a smooth road? Like you said. So it's kind of an interesting piece. Roughness is very tough even the experts even today have difficulty describing roughness, even in the highest scientific communities. If you put a polish collar below the crest, certainly we saw this with the Straumann implant, the ITI, the tissue level implant. When you have a tissue level implant, I think this will help describe what people have seen in x-rays. So if you have, like the original Straumann implant, the
Tissue level.
the tissue level, this was originally 2.8
2.8.
millimeters. Then they went a little shorter to 1.8, what they call their aesthetic plus. But why? If you put this one in the aesthetic zone, you'd have to bury it like a two-stage implant or come close to burying it the same way. If you put it right here, that's the bone, which is the tissue level, this sticks up. And so where's the biologic width form? Here's your rough surface. And here's your screw. The biologic width will form supercrestally on here. Now, but if you take this polished part, buffed and polished, it's not rough enough to integrate, and you put it into the bone. So let's say you submerge it to this point. Let's say that's how low you put it. The bone doesn't stay here. The bone will go, you know, everybody knows that you look at these x-rays, especially in the front of the mouth, where they had to push it in further for aesthetics so that this wouldn't show. When they didn't have the two-stage implant, this polish collar would be never take. Never. The bone would go right down to the rough surface, even though there was no microgap here.
Especially on the facial.
Especially on the facial, right. So what happens is that we now realize, and we know just by this implant design alone, is that the polish collar doesn't integrate. So even though it's the same titanium as this. So I think that's important for people to remember when they start talking about surfaces and so on. So the question then is, okay, so how rough? Now Brännmark's surface, the original Brännmark surface, had just little striations in here. Not very rough. Then when you put acid on it, you start to see more something three-dimensional. And you blast it first with different particle sizes, you get even rougher surface. So the blasted surfaces and etched surfaces seem to be the key to allowing integration. And it's three-dimensional. It's almost like bone. It's like an open structure. And of course the bone grows in microscopically and then locks the implant in. And that's why integration does so well. Now there are other things like adding fluoride, like like OsteoSpeed. You might then turn into something that can attract bone and maybe even manipulate the bone. And you may want to comment on that because this is an area of your expertise. Adding fluoride, or chemically modifying the surface. That's one thing to have roughness, but now how do we attract the cells during that first 4 to 6 weeks faster, and even maybe make it denser? What have you?
Well, one of the things with my concepts in terms of how OsteoSpeed comes about is you have a macroscopic roughening that's done with a grit blasting, in this case with a titanium dioxide. Lots of different ways to do it, but on a macro scale, that's where you're getting your bone interlock. On the micro or nano scale is where you're going to have the effect of the etching with the acid. Now the acid is technically there to clean away your particles that you've impregnated into the surface of the implant. But the slight etching then creates another layer of the bumps on the road, if you will.
Bumps down in the valley. Right?
Bumps down in the valley.
Small stuff.
And that allows what I consider, when I talk about with my students, you have bone growing in first, but then you have bone adhering into these small little, if you will, nano pits on that surface, and that's what is a manifestation of this etching process, in this case with the hydrofluoric acid.